I am Dr. Pete Thomas, Chief Medical Correspondent for MD Newsline, also internal medicine physician, HIV specialist, men's health specialist, and medication assisted therapy specialist. I'm from Chicago, happy to be here to interview this awesome cardiologist, and I'm looking forward to a great discussion.
Good afternoon, everyone. I'm Dr. Emeka Anyanwu. I am a general cardiologist based in Philadelphia. As I said, focus is mostly general non-invasive cardiology, but also I spend a good amount of my time doing clinical innovation and clinical informatics work.
In your opinion, what are some really recent cardiac advancements that will impact patients' care?
Yeah, the beautiful thing about it is there's, the full stack, so to speak, of cardiovascular care has seen a lot of advancements in the last several years, from the medication standpoint, we're, unlocking medications that treat entirely new categories of disease that we didn't have focused therapies for. Something like ATTR cardiomyopathy, for example, or hypertrophic cardiomyopathy, we now have dedicated medications for. In terms of diagnostics, we now have more nuanced markers for cardiovascular disease beyond just the basic cholesterol panel. So things like Lp(a) or ApoB give us some additional clues as to why some people have cardiovascular disease much earlier than others. And then, there's some kind of familiar trends. We're continuing to see new, or not new, but old diabetes medications become cardiovascular medications. And so GLP-1s are very popular, but also SGLT2s, medications that were both really kind of came to the market as diabetes medications, and then we're finding more and more expanded indications and actually, in some cases, clinical benefit for patients with heart failure or other types of cardiovascular disease.
I really am intrigued by this idea that we're using past diabetes medications for now cardiac problems. And I can really see where this could decrease medication burden for patients. Can you comment on that?
Yeah, I think that's a really good point, because one of the exciting things is you might have a patient that has, 2 or 3 diseases that might all be covered by one medication. There's this term we use sometimes known as metabolic syndrome that is basically a grouping term for diseases like obesity, hypertension, diabetes, and sometimes other forms of cardiovascular disease. And some of these diabetes medications can cover 2 or more of those conditions. And so one, it allows the patient to feel like, hey, I'm kind of getting bang for the buck. I'd like to take as few pills as possible, and this one pill is covering multiple conditions. But then also it allows for an opportunity of collaborative care between the cardiologist, the endocrinologist, the primary care doctor, obesity management doc, et cetera. So definitely that is a big selling point of some of these medications coming over from the endocrinology world.
As a leader in cardiovascular informatics, can you tell us some of the more innovative things that's coming out of cardiovascular informatics?
I think there's a lot of opportunity, a lot of excitement, a lot of buzz. Cardiology and medicine are just like everywhere else where AI is, trying to be applied to almost nearly everything. And so there's a lot going on. But, the parts I'm excited about are areas where I think AI can be used in an assistive fashion and responsibly. And what the parts that I find really interesting are, there are a lot of menial tasks in either the operations of medicine or the clinical practice of medicine that involve a lot of pointing, clicking, reading, moving, dragging, dropping, copying, and pasting that don't require the people doing them to think that much. But all of that is prep work. But by the time you get to the end, before you move that document or finalize that report on that cardiac MRI or that heart ultrasound, you might still need to say, okay, now does the story I've put together in this document or this report really match how I feel about this overall case for this patient? And so I think some exciting ways to use AI as an assistive technology is to kind of cover that first, 80%, 70%, whatever it is, right? To cover all the pointing, all the dragging, dropping, all that busy work, and then kind of speed us up right to this last part where somebody now unburdened of all the manual tasks can say, okay, now, given what I see here, having talked to the patient, having looked at this report, do I think that the information pre-filled by this AI assistive technology is representative? And the answer is usually never. But still, now that you've saved maybe 10, 15, 20 minutes, depending on what you're doing, not having to do all the basic stuff up front, you can maybe spend a little bit more of your time kind of thinking of the nuance, kind of adding that stylistic flair on that, radiology or cardiology report, or, trying to think more about the exceptions in your clinical operation workflow with patient scheduling and, incoming medical records. I think using some of these technologies upfront to unburden and allow the human to kind of focus on the exceptions, because that's where humans are much better than computers, is like a really great application for AI. And I think it's definitely coming down the pipeline.
That is great. I would have to say that's probably the best explanation I've ever heard.
One that's being continually refined. So ask me 2 weeks from now, and hopefully it'll be a little bit crisper, because the technology just keeps moving at such a rapid pace.
And maybe the lay audience might not completely comprehend the amount of menial tasks that we do have to do in every interaction with every patient, and just working with electronic medical records, and how the little things, just refilling the medication, can be very challenging. And this idea that informatics could take that off of our plate so the provider can spend more time on more critical issues. Phenomenal. Thank you. I appreciate that. Thanks so much. Can you share your thoughts regarding your approach to getting patients involved in clinical trials, particularly minority patients, and explaining the risks and benefits to them, particularly around cardiovascular trials?
That's a good question, and I thought you might ask, but I think one important thing to clarify is that, the risks and benefits of a trial, as a provider in a cardiovascular department, I might have some idea of the general purpose of the trial, and I've heard about the drug. Maybe I've read an abstract or two, and I have some general sense of what it's supposed to accomplish, and maybe some of the highest or most commonly encountered side effects. But the truth is, the risks and benefits and all of that's on the responsibility of the principal investigator and their team, the person running the trial at that site, to explain all of that to the patient. Now, I think the role of the provider that you have a direct relationship with on your primary cardiologist or primary care doctor is to help you try and decipher some of that medicalese, try and drive home some of the high points, and kind of reassure you not to worry about things that are aren't as big of a deal or far less likely to happen. And then beyond that, I think it's really all about timely approach and that relationship. And so I think it's important to kind of speak to patients about these opportunities when they are in the right frame of mind, and when the problem that could be addressed by the trial is kind of front and center. And so I think a really great approach that I've seen by clinical trial teams is to approach a provider when they know that provider is going to be seeing the patient was recently hospitalized or discharged, and try and use that period where both the provider and the patient are thinking about their disease, maybe an acute event, an admission, a surgery, and really using that as a time to focus on, is this clinical trial for you? So I'm kind of blabbing on here, but I hope I've answered your question.
No, you absolutely did. I think another issue that I deal with is to make sure my patients understand by no means are they forced to do this, no matter how much they might have been offered in terms of incentives, and it might be someone that's already involved in their care, that they have the autonomy to say no, and that they're helping us to better understand how this medication might impact a variety of populations. So I totally agree with you, and I commend you for being that advocate.
I actually really like that word you used, autonomy, because I think it's actually one of the most powerful parts of relationship building between a healthcare team and a patient. Is, I am a physician, I know the tools, I have access to the tools and others who are experts with the tools. I have an idea of how they work, but it's ultimately your decision to, decipher what I've told you, ask questions, and then decide if you want to move forward or not. And I think one of the things that can be really enhancing about developing that relationship is, just giving time for pause. I'm going to talk to you about it. Go home and think about it, read about it, search on the internet. Maybe you'll find things that, scare you, come back in, we talk about it. Not every situation allows for that kind of time, but many do. And so I really like the idea that, I'm sharing the information with you, but ultimately it's your decision as the patient. And so, yeah, autonomy, I think, goes a long way in making sure the patients know that they have that autonomy when it comes to trials or just general care.